Hello everyone, welcome to HIM 216. This is your last chapter this semester for coding. And in your textbook, we're on page 277. There are a few abbreviations and acronyms on 277 and 278. And then there are glossary terms on pages 305 in 306, and there are many more of those than we had in chapter 12, so be sure to come and read those terms. Now, chapter 13 in your textbook is chapter 4 in ICD-10. Endocrine, metabolic, and nutritional diseases. I'm sad to say you'll do a lot of coding out of this chapter because so many people have diabetes. And that's what the guidelines are focused on in this chapter. When you look on pages 278 and 279, we actually have guidelines related to diabetes mellitus and secondary diabetes. Now, before we begin, and really diabetes is the most challenging coding from this chapter, I want you to turn to page 286 before we start looking at the guidelines. And diabetes is an awful disease. It affects so many systems of the body. We actually have recently had coding guideline changes with regard to diabetes, and we'll look at what those changes are actually when we're in the index. But diabetes mellitus, it's a chronic condition. Once a patient is diabetic, they're pretty much always diabetic. Patients with diabetes mellitus type 2 can control their disease process sometimes with lifestyle changes, exercise, and diet. That's difficult to do. Many patients don't accomplish that. Diabetes mellitus, we have type 1 and we have type 2. And when we're in this section and we go to the diabetes mellitus codes, we have diabetes mellitus due to underlying condition, drug-induced, type 1, type 2, and other specified. In your textbook, it tells us that diabetes can be caused by a problem with insulin production in the pancreas, or it can be caused by the cells not appropriately using the circulating insulin. When we look at type 1 and type 2, they vary in their pathology, the age of the patient. It used to be, now a type 1 diabetic is what we also have called juvenile onset diabetes. These are people that must have insulin or they will die. That is a type 1 diabetic. They must have it. Now type 2 diabetics, and now we're seeing more and more children that have type 2 diabetes. They're not juvenile, they're not type 1, they're type 2. They can be controlled with medication, oral medication, exercise, diet. But there are times when patients with type 2 diabetes require insulin. It doesn't change the fact that they're still a type 2 diabetic. Just because they're using insulin doesn't mean that they have become a type 1 diabetic at all. And when we're looking at documentation, if the only documentation we see is that the patient has diabetes, we actually code it to type 2 diabetes. If the documentation says that the patient is insulin dependent, we code it to type 2 diabetes. In order to code a patient as type 1 diabetes, we need documentation that the patient is a type 1 diabetic patient. So the use of insulin doesn't determine what type of diabetes we select when we're coding. Be sure to read this information carefully about the different types of diabetic patients. Your book tells you that there are 2 types of complications that can occur with diabetes mellitus. One is an acute metabolic complication that's part of the diabetes itself, like ketoacidosis. Then the other is a complication or manifestation that occurs in another part of the body due to diabetes. So a patient that develops peripheral neuropathy, which means they, for instance, have trouble feeling the bottom of their feet. When diabetic patients go to the doctor, one of the things the doctor is supposed to do every time they go is check their feet. And a lot of times you'll be in a doctor's office and it'll say, "Are you a diabetic patient? Make your physician check your feet." And they're looking for circulation in the feet. And then they also take a little tiny appliance that they can poke the toes and the bottom of the feet to see if the patient feels that sensation. If they don't, they have typically developed diabetic neuropathy, which is just not a great thing. Patients with diabetes can develop circulatory problems. They can develop patients with diabetes have a harder time healing from surgeries, from injuries. Patients can get a cut on their foot. It won't heal well. They can end up with gangrene and potentially even having one of their appendages amputated. Because of that, now we have great care now in wound centers, so many times that can be diverted, but not always. Diabetes can affect all different types of body systems. So let's look at it in the index. Now when we go to diabetes, this code E11.9 is actually the default code. This is type 2 diabetes without complication. When you're coding, if the documentation tells you that the patient's a diabetic, we code it. And the code we use is E11.9 if there are no other manifestations documented. If the only documentation is the patient's a diabetic on oral medications, E11.9. If the patient has any other manifestation, we cannot use this code because you see it says without complications. So if there are any complications, and all these terms over here under with are considered to be complications, then we can't use this code. But if the only thing documented is diabetes, then we can use this code. This category that we're in, let me go to the top, is category E11, and that's the category for type 2 diabetes mellitus. You'll see we have some includes notes here. We have a use additional instructional note here. We have an excludes note 1 here. And if it's gestational diabetes, we're not coding it here. If it's neonatal diabetes, we are not coding it here. If it's diabetes due to an underlying condition, we're going to category E08. If it's due to a drug or a chemical, we're going to E09. And an example of a drug or a chemical could be steroids. Sometimes people who abuse steroids, weightlifters, they will develop diabetes. And that is diabetes that is due to a drug or a chemical. Sometimes people that have their pancreas removed are diabetics, but it's post-pancreatic, post-pancreatectomy diabetes mellitus, and that's category E13. Post-procedural diabetes mellitus, E13. Secondary diabetes. There are some health disease processes that cause diabetes, and those are considered to be secondary diabetes. And of course, if they're type 1, then they're going to category E10. Well, when we look at this code in the alphabetical index, what comes up are the codes for type 2. And this if the patient has any of these conditions, it is considered to be a manifestation of their diabetes, and we use these codes. We can use as many of these codes as we need to. If we have a type 2 diabetic who comes in and they have cataracts, and they have chronic kidney disease, and they have a foot ulcer, we are going to add codes for all of those conditions. And here's neuropathy, E11.40, peripheral angiopathy with gangrene, polyneuropathy. So these are all, here's just a skin ulcer. So all of these, if the patient has these conditions, then documented in the chart, we don't need, the new guideline says we don't need the physician to document a cause and effect. We just code. Now, as we come down through this category, we can see I've seen documentation of brittle diabetes, and you have an instructional note, see diabetes type 1. Diabetes due to autoimmune process, go to type 1. And now we have due to drug or chemical, and that's E09.9, and that means that we only use that code if there is no other complication documented. And if we go to the beginning of this category, we can see that it's drug or chemical induced diabetes mellitus. We have our instructional notes that we have to come up here and read, and then we have that same term with, this is the same things we saw when we came to the category. The codes are different, terms are the same, codes are different. And then we have the category for due to underlying condition. Again, only this code if there are no other complications. Come up to the beginning of this category, and here you have a hint, we have a hint of what some of those underlying conditions could be, because we have a code first note. Code first the underlying conditions such as congenital rubella, Cushing syndrome, cystic fibrosis, a malignant neoplasm, malnutrition, pancreatitis, and other diseases of the pancreas. So those, the condition, the underlying condition that is causing the diabetes mellitus is sequenced first, and then the code for the diabetes mellitus. This is important because you don't have that instructional note for type 1 or type 2 diabetes. Let's go back and look at due to drugs and chemicals. We didn't look at that. We have an instructional note here that says code first poisoning due to drug or toxin if applicable. And it may not be applicable if they have a long-standing condition. So we do have some additional instructional notes there. And then we have some other terms. Gestational, there's a specific code. It means that the patient was not a diabetic before they got pregnant, but during the pregnancy they developed diabetes. We'll talk about that more when we are in that chapter. Then we have specified type NEC, E13.9, again, without any other complications documented. And then we do have some instructional notes at the beginning of this category. And again, all of these conditions are the same. Then we get to diabetes type 1. And typically what you're going to be doing is searching for type 1 or type 2. And you can see if I put in type up here, it just comes up to type 1. But if I put in type 2, then it's going to pop down to type 2. So type 1 is listed first because 1 comes before 2, and there's type 2. And then again, all of these conditions listed with the codes, you can code as many of them as you need to, and we only choose the default code in either of these categories if there are no manifestations. So we'll go to E10, which is type 1, look at the codes at the top, and you can see that this includes brittle diabetes, diabetes due to an autoimmune process, juvenile onset diabetes. We do have an excludes note 1, and basically it's diabetes due to something else. Now, poorly controlled. You may see documentation of poorly controlled diabetes mellitus. Well, if it's poorly controlled, they have hyperglycemia, or they may actually have hypoglycemia. So you'll notice right here it says out of control and poorly controlled. You have to know the type of diabetes, and then you choose that term, hyperglycemia. So I go to diabetes, type 1. What happened to me here? Oh, I have to type in the with. What am I thinking here? Okay, with, there's hyperglycemia, hypoglycemia. If we look at hypoglycemia, that's in a category for that says you can differentiate whether or not the patient has coma with this particular category. And then if I were going down to diabetes type 2 and looking at hyperglycemia and hypoglycemia, you can see that again the hypoglycemia includes with coma. If a patient's blood sugar becomes too low, then they can pass out from it, they can go into a coma, they can die from it. So carefully read this section on diabetes mellitus. Let me know if you have any questions about diabetes mellitus or secondary diabetes. Now let's go back to the guidelines on page 278. And basically it tells you things that I have gone over. The age of the patient isn't a determining factor, although usually type 1 develops before a child reaches puberty. It can be called juvenile diabetes. But we're seeing more and more children that are obese that have diabetes, and those are typically type 2. And in this example, there's this a 16-year-old that has obesity and type 2 uncontrolled diabetes. We have to put in uncontrolled. And uncontrolled, if we put in diabetes uncontrolled, meaning hypo, we go to the type of diabetes, and in this instance we would actually want to look at the blood sugars, and it's probably hyper, meaning they're very elevated, and so we would choose diabetes. And this is type 2. Remember, this E11.9, this category is actually the category for type 2 diabetes, and we could come in and choose hyperglycemia and get E11.65, and then code the obesity. E66.9 is the default code for obesity. We don't have anything else more specific documented there. If the type of diabetes isn't documented, you code it to type 2. And then the guidelines talk about diabetes mellitus and the use of insulin. If a patient, type 1 diabetics, must have insulin or they die. But a type 2 patient doesn't necessarily have to have insulin. But if they are using insulin, we can actually assign a code to that patient under long-term use of insulin, Z79.4, and this will reflect that our type 2 diabetic patient has to have insulin. Z79.4. And again, we find that term in the index by putting in long term in the index. Yeah, if we put an insulin, nope, nothing there. So we have to remember that. We have to find that term. We have to find long term in the index. We'll talk about diabetes mellitus and pregnancy when we get to that chapter. Now, there are patients that have insulin pumps in. And when they have an insulin pump in, those insulin pumps can malfunction. And when they malfunction, if they don't give the patient enough medication, it's called underdosing. And we use this T38.3X code. Underdosing of insulin and other anti-diabetic drugs. If they get too much insulin, it's a poisoning. And where's my code? Poisoning by insulin and other anti-diabetic drugs. When we have either an underdosing or an overdosing of an insulin pump, we're going to have a code from T85.6 for mechanical complication. And we can go to mechanical complication. Let's do... Okay, so complication, insulin pump, mechanical, and typically what we're coding is a breakdown. So T85.614 is typically the code that we are using for that. And that is that mechanical complication code is going to be our principal diagnosis code in these instances. And then if it's underdosing, then we'll have either underdosing or overdosing. Then we'll have the appropriate code from the table of drugs and chemicals. And then we'll have the code for the type of the diabetes that the patient has. And type 2 diabetes patients can also have insulin pumps inserted. Then we have guidelines for secondary diabetes. This is in category E08. These patients routinely use insulin, so we're going to have that long-term insulin code that should be assigned. And when we go to we assign codes based on the sequencing instructions that are in the classification system. And so read that information in your chapter very carefully. Now for this lecture, I want you to go to page 290, exercise 13.2. And I want you to answer question number 1, question number 7, and number 9. So 1, 7, and 9 from exercise 13.2. Now let's talk about your homework for this chapter. In the chapter review, you're doing odd 1 through 19. And for questions 1, 3, and 5, each of those have one code. Number 7 has 2 codes, and there's actually a coding clinic reference. You'll see it in the tabular when you go to these codes. You may want to read that. Question 9 has 1 code. 11 has 2 codes. 13 has 1 code. 15 has question 15 has 4 codes. And so when we're looking at this is a type 2 diabetic patient that's poorly controlled. They have diabetic gastroparesis, so you have to apply the code for diabetic gastroparesis, and you also have to code gastroparesis. And then, of course, this patient is on insulin. 17 has 1 code, and 19 has 2 codes. In your workbook, you're going to be answering case scenarios 1, 3, and 9. And so in your workbook, turn to page 97. And as we look at this, we have a 30-year-old who has a history of type 1 diabetes. Now we know that he does not have a history of it. He has it. He's had it since he was 8 years old. So we don't even consider the fact that history is irrelevant here. So he has polyneuropathy. He is non-compliant with monitoring his glucose. In the ER, he had hyperglycemia. His blood sugar was over 500, so he was admitted for out-of-control diabetes. The final diagnosis is type 1, is diabetes type 1. Well, of course, that's not the only code you need. For this particular scenario, there are actually 4 codes, and 2 of them are Z codes. Think in terms of the fact that this patient is non-compliant and so he's non-compliant with his medication and he's non-compliant with his glucose monitoring. So non-compliant with medication and then non-compliant with medical treatment and regimen. So there are 2, we can zap him 2 different ways with non-compliance. Okay, so number 3. This is an 80-year-old. She was admitted because of hypoglycemic shock. She was confused about her insulin dosage and she took twice the prescribed amount. So she accidentally overdosed herself on insulin. So that means you're going to have to go to the table of drugs and chemicals and find insulin and choose accidental poisoning. She also has coronary artery disease. She doesn't have a past history of it. She has it. And she actually has a stent placed. So this is a type 2 diabetic in hypoglycemic shock with coronary artery disease, and she has a stent in. So when we're coding this, we actually have 5 codes. We have the code for the insulin overdose. We have a code for the fact that she has the hypoglycemic shock, and she has the coronary artery disease. Now, she is a type 2 patient who is on insulin, so we need a code for that. And then we also can code the fact that she has a stent placed. And that's a code for if she had its presence. So when you're looking for this code in the index, you're going to go to presence. And then let's look at number 9. So this patient came in with DKA, diabetic ketoacidosis. And if you look at in your book at chapter 13, it doesn't have DKA, but it is diabetic ketoacidosis, and it's not a term at the end of the chapter either, but it should be discussed within the chapter. So The lab showed that she had glycosuria, ketonuria, and acidosis. So they admitted that patient and they started a sliding scale of insulin. And the patient doesn't have a history of diabetic retinopathy. They have diabetic retinopathy, and they do have a history of kidney stones. So this is a type 1 diabetic patient in ketoacidosis. And you'll have 3 codes for this: the diabetes type 1 and ketoacidosis, the type 1 diabetes with retinopathy, and the fact that they have a history of kidney stones. And remember that another term for kidney stones is calculi, renal calculi or urinary calculi. So that will conclude this lecture for Chapter 13, and it's the only one that you'll have. Let me know if you have any questions.